class, welcome to MedSurg 2 Week 1 Lab PowerPoint. In this PowerPoint, we're going to review some information that you've learned in previous terms and go into further detail on certain aspects. So let's dive in and talk about physical assessment of the abdomen. So the abdomen goes in a different sequence for physical assessment. Just a reminder, I'm sure everybody remembers this, but we're always going to inspect, auscultate, percuss, and then palpate with the abdomen. So always listen before you touch with the abdomen. When we inspect, what we're assessing for with our eyes is the abdomen's shape. Is it symmetrical? Is the color even across the whole abdomen? Is there equal hair distribution? Are there any bulges, scars, wounds, anything like that? When we auscultate, we are listening for sounds. So in the bowels, we have to listen in all four quadrants, and we are wanting normal bowel sounds. And if you're a person that really likes numbers, normal bowel sounds occur every minute. There should be 5 to 30. We could also have hyperactive bowel sounds or hypoactive bowel sounds. And again, you want to listen in each quadrant and describe what you're hearing. Because in one quadrant, you could hear hyperactive and the rest could be all normal, for one example. Remember that hyperactive bowel sounds indicates an increase in motility. So whatever is moving through the abdomen is moving faster. Conversely, hypoactive bowel sounds means things are slowing down in there and therefore decreased motility. When we percuss, we're testing for dullness, tympany, or hyperresonance. When we palpate, we are assessing in the abdomen for tenderness, lumps, masses, pulsations, crepitus, which is kind of like a Rice Krispie feel when you push on it, or muscle guarding. So you push somewhere and their stomach tenses up or they go to guard their stomach in reaction to your touch. Then remember that each quadrant holds different information. So this picture I like because it breaks down those four quadrants into details and helps us remember what components of the GI system is located in which quadrant. So, for example, this is helpful when we're talking about GI bleeds, just for an example. So, if it's an upper GI bleed, we are going to have a more bloody vomit, bloody emesis. And the upper GI is the esophagus, the stomach, and or the duodenum. All those things fall in the upper GI area. So you could have a bloody vomit, bloody emesis. That's sometimes associated with esophageal varices. You could have coffee ground emesis. That's more associated with an ulcer that has perforated. Any of those types of vomit are considered an emergency. Then we have a lower GI bleed, which is more the lower part of the small intestine and the large intestine. So that's the jejunum, the ileum, the colon, and the rectum. With that, you're more likely to see bright red blood in the stool. You could say that a lower GI bleed is not quite as emergent as an upper GI bleed. With an upper GI bleed, you may have some blood in the stool, but a lot of times it's hard to see because it's been partially digested. And so it's going to have a dark, tarry look to the stool. And if someone has dark, tarry stool, what we'll do is a lab test called a hemoccult. And hemoccult detects blood hidden in the stool that we can't easily see with the naked eye. So keep in mind what's located in each quadrant, and that kind of gives you an indication as to maybe why they're having the pain that we're having in that specific quadrant. So this slide talks to you about what could be the significance of the pain broken down by quadrant. So this one was a visual representation. This talks about what could be going wrong. So with the left upper quadrant, we kind of want to think, are we dealing with pancreatitis or a stomach issue? For right upper quadrant, we want to think, are we maybe dealing with the gallbladder or the liver? With the left lower quadrant, we're going to be thinking more intestines, bowels, and or the kidneys. Right lower quadrant, we're going to be suspecting appendicitis. Across the board, if you have someone that has a rigid abdomen, that is a bad sign. That is an emergency sign. Bad means it could be something like a perforation, it could be peritonitis, and it could be leading to impending sepsis and or shock. These are things that can kill your patient. So that's why we always chart whether the abdomen is soft or not. The abdomen should always be soft, because if it is rigid, that means potentially something very bad is going on in there. Okay. Let's see. So let's talk about some specific conditions next. Appendicitis, pain in that right lower quadrant is very common. You can also see McBurney's sign. McBurney's, which is in this picture here, is when the pain starts in the periumbilical area and then slowly kind of moves over a few hours down to that right lower quadrant. That is a classic presentation of appendicitis. People are also going to say they just can't eat anything. That's the anorexia, the decrease in appetite. You're going to have an increase in temperature due to the immune system trying to fight the itis, the inflammation part, and usually the white blood cells are going to be elevated. And these patients may say that they're very nauseated as well. Now, if they have this pain and all of a sudden it's completely better, that is a very bad sign. That could mean that their appendix has actually ruptured. And so the reason why we have that pain is because the appendix is swollen. If it ruptures, that swelling is immediately relieved, but the bad thing is all that infection that was in the appendicitis has now been released into the whole abdomen, and that can cause peritonitis. Which brings us to our next slide. Peritonitis is an emergency. It can lead to sepsis and shock. What you're going to see is an increase in temperature. They're going to be very painful. That rigid board-like abdomen and rebound tenderness. They could have a tender and distended and rigid abdomen. All of these adjectives are very bad. Usually what happens in peritonitis is they have to figure out what's causing it. They've got to do some IV antibiotics, IV fluids. They're probably going to put an NG tube down the patient. And they may need to go to the OR to have their abdominal cavity cleaned out. So anytime a person has an abdominal surgery or perforation of an ulcer or rupture of an appendix or trauma, peritonitis is a risk and it is very, very serious. So again, tender, rigid, distended, um, board-like, rebound tenderness, guarding, all of those things, if you see that in a patient, that should be a red flag and you should be thinking, I may be dealing with a potential emergency here and my patient might crash. So you want to notify the physician ASAP of those findings and have a fresh set of vitals. So that brings us to some different conditions. I want to talk, a lot of times they're talked about hand in hand. So it's sometimes easier to talk about how are they different. So ulcerative colitis and Crohn's disease, both of them are related to inflammatory processes in the body. Both of them have an important lab value, the SED rate. So the sedimentary rate. The SED rate is a laboratory indicator of the level of inflammation in the body, but it is non-specific. It won't tell you where the inflammation is. So that's when we correspond it with the location of the pain and the type of stools or complication that the patient is having. So ulcerative colitis, the key thing is frequent bloody stools. And I'm talking a large volume of bloody stools. And the level of inflammation that they have is continuous. And the pain is most commonly in the left lower quadrant. Contrast that with Crohn's disease. It is usually patchy inflammation, and you don't have the bloody stools. And the pain is typically in the left lower quadrant. I apologize, I'm having difficulty reading my writing. It is the right lower quadrant. So let me just repeat that so we have it straight. Crohn's disease is the right lower quadrant. Ulcerative colitis is the left lower quadrant. Now, that's not to say they can't have pain in other quadrants, but those are the common locations. Both of these conditions, we're going to try to control the level of inflammation, decrease any diarrhea, and then treat pain. So that's pretty much in a nutshell what they have in common and what they have differently. So from there, we switch over to some NG information and some reasons for NGs. So we can use NG tubes to help with decompression. So like if your patient had an abdominal surgery, the bad thing is that our digestive system wants to keep working no matter what's going on, but sometimes we want our digestive system to rest. And or decrease production of secretions. So we can put an NG tube down there and suck out the secretions. And by decreasing the secretions, it also slows down how much the GI system is working. And that can also help to treat intestinal obstruction. We can also use an NG tube for nutritional support and medication administration. Usually that's a short-term solution. If it's going to be long-term placement, we probably switch them out with a G tube if it looks like it's going to be around for a while, or a Dobhoff, which is just a smaller gauge tube that goes down into either the stomach or the small intestine. We can also use the NGs to collect stomach contents so that we can help diagnose what's going on in the GI system. There are some pieces of evidence-based nursing care that we need to do for anybody that has an NG. So we want to verify that placement. We want to make sure that NG is where it's supposed to be. The gold standard is for an X-ray immediately after insertion. Thereafter, we will aspirate some secretions and check the pH on pH paper, and it should be less than 4. Um, for some reason, if you can't get a good pH and you're worried it might be misplaced or in the lungs, you can get another X-ray. You'll have to contact the physician for an order, of course. It says here the least accurate is the auscultation method, and you may still see that being done on some nursing units. And that's when they connect a syringe to the NG and kind of push some air in it and then auscultate the abdomen. That's not accurate. Um, uh, they have done studies, and that cannot confirm placement. We also want to measure the length of the tube, not only when we're placing the NG, but you want to monitor how much of the NG is coming out of the patient's nose to make sure it's not slowly migrating out to where it shouldn't be. With NGs, we have to provide excellent oral care, so that's more than brushing once a day. And the reason why is because we've got a foreign body going up the nasal cavity into the back of the mouth, down to the stomach. That can be a transmission method for bacteria. It also is going to alter the amount of saliva that's in the mouth. Um, and if we don't have enough saliva production, that allows for more bacteria to grow, and then therefore that bacteria can travel down that tube and cause problems. Providing oral care will minimize or reduce the risk. We can't give a patient with an NG ice chips unless the physician specifically said that they're okay to give. We also want to be assessing the nostril that has the tube down it because, especially if it's been in there for a while, it can cause irritation and erosion of that tissue and actually be causing a hole in their nasal cavity. We want to make sure we assess vital signs, we assess lung sounds. If your patient is hooked up to suction, you want to be looking at that drainage and saying, is it an expected finding, color, and volume? We will expect some blood-tinged drainage immediately after surgery and up to 24 hours after. After that point, there should not be blood in the NG section. Normal drainage could be anywhere from a light yellow to a deep green. So you want to check for changes in color. And then one side note is if your patient has had their stomach resectioned, you cannot replace an NG in there. Ordinarily, if an NG accidentally gets pulled out, a nurse can just put it back down. But if your patient has their stomach resectioned, we cannot do that because it's going into a surgical site. Okay, so that brings us to stomas. Stomas are basically an artificial opening of the intestine out to the surface of the abdomen. It's usually done because of cancer, um, some sort of tumor, and they need to resection the intestines. Um, Stomas are going to output stool, but they're going to look different depending on where the stoma is located and what part of the intestine is being pulled out. So, for example, if it's part of the ascending colon, the output will be very liquidy. If it's part of the transverse colon, it'll be more pasty. And then if it's part of the descending colon, it will be more solid and more like what we normally see or um, what the patient is used to producing. Um, the amount of output kind of depends on the patient and the location of the ostomy. Um, Obviously, the further along in the digestive tract, the more moisture is removed, and so you'll have a smaller output typically. Um, and then, yeah, it should look nice in a beefy red color and kind of moist. That means that it's getting good blood flow. And if it looks pale or dusky or even blue, those are signs that it's not getting good blood flow, it's not being perfused. So that is an emergency, and you would need to notify the healthcare provider of that because they may have to take them into the OR and rework it. Moving along to that, there are many different appliances that we can use to cover an ostomy. Um, the most important thing is that we start with clean, dry skin. Ideally, that skin would be all around the same height and intact. If we're dealing with folds or ridges, that's when we have to be creative and use like Stoma adhesive paste to fit into those crevices, and before we put the sticky part on their skin. Because ideally, these flanges is what we call the sticky part that goes on your patient, should stay in place for several days. And then the pouch, which goes on the flange, we could empty that. The blue thing with the circles on your screen, that's a device that we can use to measure an ostomy. When you measure an ostomy, you want it to be as close to the ostomy opening as possible without pinching it, because if you pinch it, it's going to decrease the blood flow and cause hypoperfusion and or wounds. Um, and what we would do then is cut to fit. And we can talk more about this in lab if anybody would like to practice that. This here is just another picture of it. So you can see it's got those blue lines and a little scissors on it. That's how we would measure, and then we would hold up our measure to what we would need to cut, and then we would cut it. And it's tricky to cut those because you have to cut it but not cut the pouch, because then you have a hole in your pouch and then you have to start all over again. So that brings me to the end of this short little review slash hopefully helper for week 1 lab. I appreciate you listening, and please let me know if you have any questions or if there's anything that I can expand upon. Thanks so much.